Okay, so the first thing they want us to talk about today is filtration. Filtration is the movement of plasma and the components from the blood into the nephron, so it can be filtered and then secreted or resorbed, go through and be kind of purified and stuff for our use and stuff. So what happens is blood comes in here to the glomerulus, and then it leads to the efferent arteriole. And there's some special cells here that allow us to filter, and everything is filtered based off of size and charge. So in order to be filtered, something is usually small. So you have small and positively charged. Negatively charged things, unless they're really, really small, don't usually get through. So things like chloride and bicarb, they can make it through because they're small and the negative charge isn't huge, but anything that's negatively charged is repelled. And this is because of the 4 different layers that they go through for the filtration membrane. You start here with some epithelial tissue, which is what is the first barrier for the filtration barrier. So what it does is it's called fenestrated capillaries. And the fenestrated capillaries, it has some windows in it, some little fenestrates, some windows that allow things through. And they only allow things based off of size. So that'll let them through. And then the next thing it comes up to is the basement membrane. And the basement membrane of the capillary, it also does some negatively charged stuff. So it'll filter for negatives, some like negatively charged. So it'll make sure negative charged things don't get through. And then it'll come to the next, which is another cell called the podocyte, and it kind of wraps around the capillaries to make sure that they don't burst from the high pressure that we'll get to in a second. And they also filter for size. And then the last thing is the podocytes have these little slits with films in them, and that is the last barrier. They go through that 4th barrier, and it filters for size and charge. If they're big enough, if they're small enough to get through that slit and positively charged, or the few negative charges they can get through, they get through. And the way this works is blood comes in, and we have some hydrostatic pressure from that blood coming in, forcing the serum out of the glomerulus and into the nephron. And that is going to be about 55 millimeters of mercury there. And pushing back against that, we have some pressures that are kind of pulling back into the capillary, because we have our BCOP, just like we did with other stuff, the blood colloid osmotic pressure that is pulling back in. And we also have a pressure from the Bowman's capsule, and it's just called the capsule pressure, so I'll put CP here, and it goes in, and it's about 15 millimeters of mercury. And then the BCOP in here, that is again also just about 28, like it was before, 28 millimeters of mercury. So when we add these all up and we do our math, we get about, 12 is the final filtration pressure going through. And so that'll push it in, and that is where the other processes of the kidney, like reabsorption and secretion, all that happens. So let me fix my little glomerulus and Bowman's capsule here. Okay, so we went through that filtration membrane, and now we're in, let's go for a little ride. So we went in here, got filtered. So this is stuff like glucose, water, sodium, potassium, chloride, amino acids, all those sorts of things, really small positively charged, and some negatives like bicarbonate that gets filtered through there as well. And that leads us to discussing how do we measure if something is filtering correctly or at the correct rate. So we have a measurement called GFR. I'm just going to write this one right here as well. So we have GFR, and this stands for glomerular filtration rate. So this is, we can use this to measure the rate of something filtrating through the glomerular into the nephron, but only if it matches certain criteria. And that criteria is it can't be secreted, it can't be reabsorbed, it can't be metabolized in the body can't create it. There's very few molecules that can actually give us a solid GFR, because it has to be filtered, and then nothing as it comes through the nephron down into the collecting duct and out through the urine. It has to stay in and continue through in order for us to get that. And the way we calculate this is our GFR is going to equal the urine concentration of our substrate, and then the V, which is the urine rate, or the rate at which we get it through, over our plasma concentration. So what this means is if we have something come in at a certain concentration in the plasma, it gets filtered and through, and then it comes all the way through, and we can measure that concentration in the urine, and we know how fast it was produced, how much urine was made, kind of the rate, like the so many milliliters per hour per minute is usually we measure in per minute. Then we can find this GFR. And the normal GFR for people is about 125 milliliters per minute. And that's important because this tells us how well we're filtering. If we have a GFR for something and it goes up, that means our GFR is up, which means we're maybe filtering too much. That means we may have too much hydrostatic pressure in here, or something that's forcing too much into the nephron and out, which means we need to take care of that. And if it goes lower than 125, it means there's something buffering and stopping us from filtering, which also needs to be taken care of. And the way we measure this is there's a compound called inulin. It's filtered freely and it doesn't get reabsorbed or secreted. It's not made in the body. It's given to people. They take it, they drink it, they get it injected, and then they give them some time to urinate. We measure the volume over the time that it took them to collect that volume, and that gives us V. We measure the concentration in the urine that we get, and we measure the concentration in their plasma, and we can find their GFR. And the reason this is actually, GFR is important, is because our body has negative feedback mechanisms that helps to control the GFR. So if we have a low GFR, that means we're not filtering. And there's some macula densa cells right here that will measure that. They'll feel that we aren't going enough. So if we have a low GFR, the GFR, we go to the macula densa, which will then release something that will change the hydrostatic pressure. So we need more hydrostatic pressure. So what are we going to do? We're going to vasodilate here to allow more blood in, more pressure, right? So what we do is we release nitrous oxide. So we go and that will vasodilate here and allow more coming in. So that in turn causes vasodilation, VD, which is an increase in hydrostatic pressure, which would lead to an increase in GFR to compensate for that. So this is a negative feedback loop. What if this changed? What if we're now experiencing too high of a GFR? Again, we go to the macula densa cells, they measure sodium chloride and say, okay, we are filtering too much, we are putting too much in. So in that case, we would release adenosine, which would cause a vasoconstriction here on this afferent. A vasoconstriction, which would decrease hydrostatic pressure and in turn decrease the GFR. And so those are the negative feedback mechanisms on this side, that we're going to change that vasodilation, vasoconstriction based off of the GFR, filtration rate, measured by the macula densa cells that are along the nephron and by that glomulus. So then, but because there's also arterioles over here that can change, so we can actually also vasoconstrict and vasodilate on that side, changing the hydrostatic pressure here. So what we do on that side is it's a little different because it doesn't go through the macula densa cells. We don't necessarily get that whole negative feedback loop. But what we can do is there are some stretch reflectors or receptors in here. So if they're stretching too much, they release more calcium, and that can help constrict that. Because if we're having too much leave, the hydrostatic pressure is going to go down. So the hydrostatic pressure goes down, and these are stretching. They'll release some calcium, which will cause the smooth muscle to constrict and increase that hydrostatic pressure there, increasing the GFR to filter more. And the other one is our sympathetic nervous system. Our sympathetic nervous system, right? Yeah. So this one is a little different. Our sympathetic nervous system can also cause this to constrict and increase in here. It does it a little faster and stuff, but it constricts and causes that. So we can actually control this filtration rate on both the afferent and efferent, just based off of different mechanisms there. Okay, now, so we've gone through filtration, GFR, everything. Filtration's done, we've filtered something. So now we need to look at what happens after filtration. First thing that happens after filtration is reabsorption. Reabsorption happens in these cells along the edge that are running by another set of, so this efferent arteriole comes off, and it can kind of actually it runs into another set of capillaries that crisscross and run around the nephron, but for our purposes today, we're just going to draw it like this, kind of a cartoonish look, but that's what we have to talk about. So filtration takes stuff from the blood to the nephron. Reabsorption takes things from the nephron back into the blood here, into these other capillaries, the peritubular capillaries. So these peritubular capillaries, they're gonna take it out and then as well to return it to the body so we can have things we need. And the main thing that actually drives most of reabsorption, pretty much all of reabsorption, is sodium. Sodium is a big player here. So, to illustrate that, I have a cell here, one of these kidney cells. And so we have this blood vessel, this capillary right here, okay? And then this over here, we'll do it in blue. I'm just gonna draw one because the lumen of the nephron is actually, has these cells on both sides. So this is the nephron lumen, and this is the capillary. So I have one transporter here, and I'm just gonna kind of erase and show what everything kind of does through that one transporter. But also, a big thing, the biggest transporter in this whole thing is the sodium potassium pump. So we're gonna take sodium out, put potassium in, and that creates this gradient here that allows us to move sodium from the lumen of the nephron into these cells and eventually out the other side. So we have this transporter here, but we also have, I'm just gonna do it this way, aquaporin channels for water. So what happens is as sodium moves into the cell, water follows it. And sodium is actually gonna be we use it as a second active transport here, and we use this gradient that is produced by that pump to move stuff in. The first one we're gonna look at is going to be glucose, and we're gonna start at the proximal convoluted tubule, and then we're just gonna work our way through the nephron and talk about how this works. But so in the proximal convoluted tubule, we have sodium and we have glucose here in the urine, or in the nephron, right? So what happens is glucose is 100% reabsorbed here in the proximal convoluted tubule. So sodium will come through this transporter and it'll bring glucose with it. And this transporter, as far as glucose is concerned, is special. It is called the SLGT2. And then there's also another channel over here that will allow glucose to be taken out. So if we get glucose here, it will come out through here and back into the capillaries. And this is called the GLUT2, or the GLUT2. So that's how glucose is used. So sodium takes it with it into the cell, and in doing so, it also brings water in, and then water comes out here as well. So that is the breakdown of glucose. Next one, we are going to change this, erase that. Okay. Next one we're going to talk about is the amino acids. So amino acids are pretty similar to glucose. I'll just do AA there, amino acids. And they're the same way. Sodium goes in and it pulls an amino acid with it. And while sodium's moving in, water's moving in and across and out. And then these amino acids are also being transported into the blood through transporters on that side of the cell. Same with lactate. We have lactate in here. Lactate comes through, same way. And transporters through to the blood. A lot of this stuff is Symport with sodium. They get taken in and used or put into the blood and to the body to use, and that's all done by this gradient of the sodium potassium pump that's established. The one special one that we get to look at right now is hydrogen, and it will actually help with some other stuff that we'll get into in a second. Hydrogen is an antiport with sodium. As sodium comes in, hydrogen comes out. And that's important because we have something called bicarbonate in our nephron lumen. Nephron lumen bicarbonate is, the base in the buffer system. So if we need to get that back into the blood, it doesn't have a transporter on the cell, but it also is too big to just passively transport, and it's negative. So how do we do it? Well, we have water out here, and we have water in here. And water is a big part of becoming bicarbonate. So we have these little enzymes out here. They can be free floating. They're on the cells, and they're also inside the cells. And these are called carbonic anhydrase. Carbonic anhydrase, yeah. So carbonic anhydrase, they are the enzymes that actually form bicarbonate, and they can do the reverse reaction too. So what happens is out here we have H2O, and we'll have some bicarbonate, HCO3, and then this hydrogen comes out. This hydrogen comes out, H plus, HCO3 minus, and they both come here to the carbonic anhydrase, which in turn will spit out H2O and CO2. Well, we can take H2O in through aquaporin channels, and CO2 actively diffuses across the membrane because it's small and uncharged. So what happens is now we have H2O and CO2 in here, and we have carbonic anhydrase. Carbonic anhydrase will take those, and it'll form bicarbonate again. And it'll take these HCO3 minus and this H plus, which will go out. And then bicarbonate can be taken back into the blood through transporters. And that is how we actually transport bicarbonate, is through this hydrogen and the water that goes in. So it's a little bit of a special one. Has some mechanisms with it. And then the last two big ones that we need to talk about in the proximal convoluting tubule. Let's do this. That is potassium. I'm just going to erase that and redraw it. Okay, is potassium and calcium. So potassium and calcium, they are involved in what's called solvent drag. So we have these aquaporins. H2O comes in and across and out. Well, as it's doing that, it can take through these paracellular space, so there's a little space here between the next cell that looks like this, and it will actually bring potassium, K plus, and calcium, Ca2 plus, and it'll bring them through and into the blood, or into the interstitium to be put into the blood. And that is how we reabsorb potassium and calcium. My drawing is just getting worse and worse. That's okay. All right. So now that we're out of the proximal convoluted tubule, let's get into the proximal straight tubule. And this is where the chloride I mentioned earlier, chloride will come later, chloride comes in now. So we have a transporter here, and we still have that sodium and hydrogen transporter, so I'll do that one in blue up here. So you have sodium coming in, hydrogen coming out, And here we have chloride. And then we have some anion in here. So as the anion comes out, it pulls chloride in. And then this anion and the hydrogen that just came out, so we have H plus that just came out, and this anion, so we'll just put a negative charge, they will come together and form some sort of weak acid that will then come back across in here before it can dissociate back into that hydrogen and the anion and continue to move chloride. And chloride, it has a special channel on the back side of the cell here called CFX or CFTR, which will take that chloride and it will put it into the interstitium so it can go back into the blood. Alrighty, so that's the only thing that really happens in the really big ones that happen. And obviously we're still moving water across because as sodium comes across, water comes across. But the next thing we get to is, I'm going to leave that there because it's always there, the descending tubule. So this portion here, so we got the proximal convoluting, the proximal straight. Now we're in this descending tubule down here, and it's really only permeable to water. So we have some sort of gradient, this sodium gradient, and it is pulling that water in. H2O, it's pulling that water in and through. So the reason this is important is because this is where we concentrate the urine. Through this portion here, it's been at 300 milliosmolar because as we pull solutes out, we pull water out. So the overall volume is going down, but the concentration is remaining the same. So this is where we're changing concentration because we are not seeing any ions move here. We are just seeing water move. So if we start at 300 here, and we're removing water, down here we could get up to 600 milliosmol in certain nephrons, and in the cortical nephrons we'll get down to 600. In the juxtamedullary we can get down to 1200, or up to 1200 milliosmols. But for all intents and purposes today, we'll just look at 600. So that's the descending tubule. And you can also get water coming through this space in between the cells here. There's also stuff coming through there. And then as we flip this loop and come up the ascending tubule, we actually close off these aquaporin channels. So we have no aquaporins, and then this space between the cells gets closed up as well. So now water that would usually come in is getting bumped back out. And we have a special little transporter here, dude in green, that brings in sodium, potassium, and chloride. And we've seen this before, but it just brings these three ions in to the cell. So now we're actually diluting the urine again, or the stuff in the nephron. So we'll start at 600, and as we move up the ascending tubule, it will go back down to 300 as we remove ions from the concentration there. And then as we get here, we have those macula densa cells that I mentioned earlier, and they are kind of the they're like the final check. They'll check everything. I'm just going to redraw this cell because it looks like I've drawn it about 1,000 times, because I have. So we have these macula densa cells. And they have a little sensor here that reads sodium chloride. It'll bring those in and it'll sense those. And depending on what it senses, and we still have the sodium potassium pump and everything is still the same. It will begin regulation of the collecting duct and the descending tubule, and whether we're going to reabsorb water or let it flow through at this 300 milliosmol or even more dilute. So yeah, through there we can really get down to like 150 milliosmoles as we come up here. And so in this descending tubule and collecting duct, this is where we're gonna see some regulation. So let's talk about that. So in the descending tubule, we have a sodium transporter here called ENaC, E-N-A-C, E-N-A-C, ENaC, and it takes sodium and it puts it in the sun. Okay, so what are we doing here? We're diluting the urine even more. We're moving sodium in, we're diluting even more, but we don't have any aquaporin channels. So our H2O, it's just getting ricocheted off. There's still stuff connecting the two cells. So if I go like this and draw that other cell, we can't get in paracellular. We can't get in between the cells. So what happens is in the macula densa, we're sensing sodium chloride. Sodium chloride goes down. That means that there is a problem with blood pressure, and we activate different mechanisms to start that. And one of them is the RAS system, the renin and aldosterone angiotensin aldosterone system. And so that will release aldosterone. Aldosterone has a big role here. But let's talk about a different hormone that the brain does first, and that is the ADH. So if your body senses that it doesn't have enough water, it needs to reabsorb water. And here we have urine that can be as dilute as 150 milliosmol. So 150 milliosmol. Well, that means it's pretty dilute. So that means in these descending and collecting tubules, we have some vesicles that are full of aquaporin channels. And they have a G-coupled protein here. Probably draw that inside the cell. With a sensor for ADH. So ADH comes in and binds. It'll come down and activate these to actually insert here and put in aquaporin channels. And we still have these aquaporin channels back here. So what does that do? That allows us to take this water, and instead of ricocheting, it'll come in and be reabsorbed. And reabsorbed. So that's kind of how ADH plays a role. And then aldosterone, what aldosterone does, I'll do this in green, and I'm going to erase this capillary here. What aldosterone does, aldosterone will come in to, and I'll redraw that sodium potassium pump because it becomes very important right now. So it'll come in, we have potassium in, sodium out. Okay, aldosterone will come in and it'll actually act on the sodium potassium pump. And what it does is it hyperactivates it. So we are now pumping tons of potassium in, tons of sodium out, which increases the water's need to go in, because now we're moving more sodium through the ENaC. Water follows sodium. We're reabsorbing a ton of water with aldosterone present. And that comes from that RAS system, the renin aldosterone. So renin is released from the kidneys based off of those macula densa cells with the sodium and chloride. And it goes to the lungs with angiotensin tensinogen to make angiotensin 1, and then to make, and then to make angiotensin 2, which will increase aldosterone. It also increases vasoconstriction. So we're going to constrict this more here, more filtration, which means we can reabsorb more water later on. We're going to get thirsty. We're going to want to drink more water. We're going to add more water into the system here, and then as well as reabsorb more. So that's kind of what aldosterone, angiotensin, the aldosterone will do. And so we're now just reabsorbing water, and that can take this urine concentration from 150 back to 300 or 600. It can get really concentrated if we're in like a state of severe dehydration and we're trying to keep all the water we can. It can become really dilute, concentrated. And that's what, in this aldosterone, the kind of drawback that it has is you can actually take potassium that's flowing in and put it in the urine. And so we can lose potassium and become hypokalemic due to too much aldosterone. Hyperaldosteronism can cause hypokalemia because we're just pulling sodium in, sending sodium out, pulling potassium in, and we can pull potassium all the way into the urine and excrete it and get rid of it there. So, how does this all work? This all works because of concentration gradients. So, the reason I left this drawing up here, and I'm gonna just erase the parts that are horrible and fix them. Okay, how does this all work? So, as you're coming through the nephron, we have concentrations inside the nephron, but we also have these concentrations outside the nephron. And as you go deeper into the kidney, so deeper down this way, that concentration gets higher. So up here at the top, we're at about 300 milliosmol. And down here at the bottom, we are at 600 milliosmol. In the cortical, in the juxtamedullary, that can get down to 1200 due to urea. So in this loop of Henle, we have 600 milliosmol, and it just continues to go down. So what does that do? Here we see that as that water comes down, it sees this concentration and wants to flow out to it. So that will concentrate what's in here. And as we come up, we also see that that concentration gets less and less concentrated, it becomes more dilute because we're heading back up to this 300. And then down, as we come back down in that collecting duct and descending tubule, because in normal conditions it is impermeable to water, we're not moving water. And this is impermeable to water too. So we're only moving solutes here, and that's how we establish and maintain this, is we are now moving solutes to help maintain this. But we can see the urine concentration not change, or we can see it change if it becomes permeable to water with aldosterone and ADH. And then we also have another set of capillaries a little farther down called the vasa recta. It can also help this gradient by absorbing water and salts and other things to help maintain this gradient. So that's how the gradient established through the kidney maintains gradient inside, along with those channels and those transporters that we talked about.